Hello, my name is Andrew, and welcome to the presentation on the small intestine. We will be discussing the general anatomy and physiology of the small intestine, its three sections, which include the duodenum, jejunum, and the ileum, and some common pathologies to include Crohn's disease and duodenal ulceration. That's me. I'm Andrew. I'm a 27-year-old nurse. I got my bachelor's degree in nursing. I'm currently working in a trauma ICU in the United States Air Force. The small intestine extends from the pyloric orifice of the stomach to the ileocecal fold, which is a valve that connects to the ascending portion of the large intestine to the third and last section of the small intestine, which is the ileum. Superiorly to inferiorly, the lumen narrows in diameter. It consists of three parts. Starting from more proximal to distal is the duodenum, the jejunum, and the ileum, and the small intestine is classified as the longest part of the GI tract. In a living person, the small intestine is 10 feet in length, but about twice as long in a cadaver due to the loss of muscle tone. Its surface area is necessary for complex processes of digestion and absorption. The small intestine is the primary digestive organ in the body. Not only is it where most digestion occurs, it is also where practically all nutrient absorption occurs. Don't get this confused with the large intestine, which is responsible for the majority of water and electrolyte transport and absorption. Villi and microvilli are located on the walls of the small intestine and function to increase its surface area. This feature greatly enhances its nutrient absorption. Fixed to the surface of the microvilli membranes are enzymes that finish digesting carbs and proteins. There are an estimated 200 million microvilli per square millimeter of small intestine. Here we will discuss the layers of the small intestine. The serosa, which is the outermost layer of the small intestine, is a smooth membrane consisting of a thin layer of cells that secrete serous fluid and a thin layer of connective tissue. The serous fluid acts as lubrication, which reduces friction from the movement of the muscularis. Just inferior to the serosa is the muscularis, which consists of two smooth muscle layers. Nerves lie between these two layers and allow the two layers to work together to move nutrients throughout the small intestine. The submucosa is the next layer, which consists of a layer of connective tissue that contains blood vessels, nerves, and lymphatics. This layer supports the innermost layer of the small intestine, which is the mucosa. This layer is designed for maximal absorption of nutrients that pass through the small intestine with the presence of the previously mentioned villi and microvilli. The arterial supply of the duodenum consists of the gastroduodenal artery, which is a branch of the celiac trunk, as well as the pancreaticoduodenal artery, which is a branch of the superior mesenteric artery. The arterial supply of the ileum and the jejunum comes from the superior mesenteric artery, which splits into around 20 branches. These branches are called arcades. Arcades further develop into vasa recta, which extend onto the surface of the small intestine. Veins of the small intestine follow the major arteries and drain into the superior mesenteric vein and then onto the hepatic portal vein. Lymphatic drainage of the small intestine is via the superior mesenteric nodes. The small intestine is innervated by the autonomic nervous system. The ANS is part of the peripheral nervous system and is responsible for controlling bodily functions which are not consciously directed. The ANS can be divided into two parts, as we know the sympathetic and parasympathetic nervous systems. When the parasympathetic nervous system is activated, this increases the activity of the small intestine, which increases peristalsis and blood flow to promote digestion and absorption. And this is done via the vagus nerve. Sympathetic activation is associated with decreased activity, and blood is distributed to the vital organs. The sympathetic innervation is carried out via the superior mesenteric plexus. The duodenum is a C-shaped structure and lies adjacent to the head of the pancreas and lies above the umbilicus. The lumen is the widest in the small intestine. Begins at the pylorus of the stomach, crosses the inferior vena cava, the aorta, and the vertebral column, and passes upward and terminates at the duodenal jejunal flexure, which is its transition to the jejunum. This flexure is suspended by the ligament of Treitz, which is attached to the diaphragm. The duodenum receives partially digested food, known as chyme, from the stomach, and plays an important role in its chemical digestion. It is then prepared for absorption in the jejunum and the ileum. The pancreatic duct joins the common bile duct and perforates at the medial side of the duodenum at the major duodenal papilla. It is here where pancreatic enzymes and bile enter to assist the duodenum in digestion. The jejunum is the middle section and the second portion of the small intestine, mostly located in the left upper quadrant of the abdomen. It connects the duodenum to the ileum and begins at the duodenojejunal flexure. It's the part of the GI tract where the most nutrient absorption occurs. The inner mucosal lining has numerous prominent mucosal folds called plicae circulares. They function to increase the amount of surface area available for absorption, similar to the previously mentioned villi and microvilli. The jejunum is attached to the posterior abdominal wall by the mesentery, which is a double layer of peritoneum and allows blood vessels, lymphatics, and nerves to supply the intestines. The transition to the ileum is not sharply marked and is only visible microscopically. The last section of the small intestine is termed the ileum and is located in the lower abdomen. The ileum has thinner walls compared to the jejunum and less prominent mucosal folds. It opens to the ascending colon at the ileocecal fold where it connects to the cecum. The ileocecal fold projects into the cecum and acts as a sphincter. Although this transition is not developed enough to control movement of material from the ileum to the cecum, it can prevent reflux of material back into the ileum. The important nutrients absorbed in the ileum are vitamin B12, A, D, E, and K. IBS and Crohn's disease are common pathologies associated with this portion of the small intestine. Crohn's disease can affect any part of the digestive system, however, it develops most often in the ileum. Crohn's disease is an inflammatory bowel disease which causes watery diarrhea or bloody diarrhea and abdominal cramps or pain. This disease damages all four layers of the intestine and sometimes creates a fistula or hole through the intestine and into other tissue. In some cases, complete perforation of the wall of the intestine is seen, which can lead to peritonitis. Crohn's disease may lead to deep ulcers in the intestinal tract, giving a cobblestone appearance. Inflammation can lead to a buildup of scar tissue over time, slowing the movement of food through the intestine and causing severe cramps. Mesenteric fat wrapping around the circumference of the intestine is characteristic of Crohn's disease, but is not well understood. There is no medical or surgical cure for Crohn's disease. Treatment consists of managing the patient's symptoms, getting the disease into remission, and preventing relapses. Patients who are not helped by medications are usually treated by surgery. In most cases, surgeons remove the diseased part of the intestine and reconnect the healthy portions. Duodenal ulceration is common in the superior portion of the duodenum. The main cause is infection with bacteria called H. pylori. This bacteria can cause the lining of your duodenum to become inflamed and ulcers can form. Some medications can also cause a duodenal ulcer, particularly anti-inflammatory drugs such as ibuprofen and aspirin if taken for long periods of time. Some ulcers can be prevented with drugs that inhibit the acid stimulation and secretion, such as H2 receptor antagonists and proton pump inhibitors. Posterior duodenal ulcers erode into the gastroduodenal artery or the posterior superior pancreatic duodenal artery, which can produce hemorrhage and can be fatal. Treatment at this point would suggest upper abdominal surgery and includes ligation of vessels or coiling of vessels to stop the hemorrhage. Anterior duodenal arteries erode into the peritoneal cavity, causing peritonitis, and surgical treatment is typically necessary as well. Just as the small intestine digests and absorbs nutrients from the food we eat every day, we too, as followers of Christ, should seek Him daily and digest and absorb the many miracles of His presence. So in summary, we discussed the general anatomy and physiology of the small intestine, its three sections to include the duodenum, jejunum, and ileum, and some common pathologies of the small intestine to include Crohn's disease and duodenal ulceration. Thanks for listening.